Welcome to episode 3, season 6 of Diabetes Squad. Today we'll be talking to an incredible midwife who I basically met through the community of Diabetes Squad. She's pretty awesome. Her name is Nurse Nina. Make yourself a cup of tea and enjoy. This season we are, focusing on motherhood, the journey to motherhood, which not only involves obviously the main person, which is the person holding the child, giving birth, the lady involved in this, but also the wider family and their support network, including their caregivers at the hospital, for example, and any other peers beside them along that interesting journey. Today we have an incredible person, but mainly a midwife who specialises in type 1 diabetes, with us, who's shared through some diabetes contacts, but just talking about her own experience, but also experiences of patients and what they have to go through. So today I'd like to welcome Nina, who is a specialist diabetes midwife. Correct me if I'm wrong, at Norfolk and Norwich University Hospital?
Yes, that is correct, yes.
What is your connection to diabetes or type 1 diabetes?
Oh, it is very interwoven.
Let's go. We're ready.
Yeah. So I've been a midwife for about 20 years. And in my final year of my training, I decided to specialise in diabetes because I thought it was really interesting. And after writing a essay on type 1 diabetes, I ended up getting diabetes. I don't believe there is a correlation there. I think that was just pure luck. And that cemented my interest in diabetes in pregnancy. It is so fascinating how diabetes can affect pregnancy and how pregnancy can affect diabetes. It's wild. There's nothing else like it. So I worked as a midwife for many years before specialising in diabetes. I've been doing that for about 9 years now. Wow. And now I tend to specialise in technologies like hybrid closed loop in pregnancy, and how we can get better support for people on hybrid closed loop, and to make sure that everyone's being offered hybrid closed loop in pregnancy as a top priority. So I get the pleasure of working with NHS England on the rollout of hybrid closed loop in pregnancy, and I get to travel around and teach other people about how to support people on hybrid closed loop in pregnancy, because it's quite niche. So I have the best job in the world.
Absolutely.
And it's like a job and a hobby and part of my life, obviously. So yeah, there's a lot of interconnections there.
There is. I mean, I'm just going to break it down little segments. When you were diagnosed, did you have the classic, the 40s, the symptoms, were you in denial, or like what was the situation?
So actually, it was almost identical to your diagnosis, Jenny.
Oh, nice.
So like listening to your podcast about your diagnosis, I was like, is she talking about me? And I was, just busy. I was a third-year student midwife. That's hard. Trying to write a dissertation in the day, working night shifts, not sleeping. And I went to work, and I was tired. And I got blurred vision. I was drinking a lot. And sometimes people without diabetes say I'm a bit thirsty. And I'm like, oh no.
It's different. It's totally different. Yeah.
I think I was not about like 20 litres in a 12-hour shift. And to really sort of hammer it home, I was going hard on the full sugar Coke. Is nothing better when you've got that thirst than a crisp Coke.
It really quenches that thirst.
It really quenches it for about a minute. At the start of the shift, I was fine, and by the end of the shift, I had to go and find a woman's partner to say, "Oh, she's in labour," and he was in the canteen, and I was looking around, I was thinking, can't actually see anyone's faces here. Like, this is not okay. But not one person suggested it could be diabetes. And the next morning I went to Specsavers and they said, "Oh dear, this is not good. You probably got diabetes, or you've got a really severe eye problem." And I thought, I'll take the diabetes because, I don't want to lose my eyesight. So rocked up with a blood sugar of the classic 33, which is just as high as the meter goes.
I was going to high five you metaphorically, because I feel like that's literally my number.
33.
But it's not the most appropriate thing to do. But I know that feeling.
Yeah,
It's sort of like an outer body experience, right?
Yeah, yeah. And something actually really, I think there's this like golden moment around the time of diagnosis where if you do it right, you do it really good. And if you do it wrong, it stays with you forever. And I remember going to the GP and they said, oh, we haven't got any appointments. And I said, I really need to see you today. Like, you know, the optician has said this is urgent. And I said, I'm really thirsty and my eyes are blurry. And they sort of said, yes, you know, you're trained for midwife. We do have a tendency to overdiagnose ourselves with things, don't we? You know, and it was really patronising. And my boyfriend at the time, who's now my husband, was waiting in the waiting room, and then all of a sudden, you know, it was all hands on deck. Go and get your boyfriend, like get her boyfriend in, we get her up the hospital. And I thought, and it really created a feeling of not wanting to make a fuss for the rest of that journey. And, you know, like how silly I was for going to the doctor, even though it ended up being diabetes. And I think you can really see how people with sort of big sort of chronic conditions, it only takes one wrong thing, you know, and it really changes your perception of it. So it's taken some time to get past that, but yeah, I was very lucky because I wasn't really, really poorly. You know, I was all right. My eyes got better, and yeah, onwards and upwards.
I think you're absolutely right. And coming into the wonderful world of trying to start a family. So, you know, trying to start a family, I've said this and I'll say it again. When I was diagnosed, the biggest worry that my mother had was A, will anybody want to be with me? And B, will I be able to have a child? As her only daughter, she really was very passionate about it because she wanted me to experience what she's experienced. And I love big families. Sure. And that was just, it was almost like an elephant in the room in the first couple of months when I was diagnosed. And I was only 20. I wasn't even with anyone. I wasn't even thinking about having kids. But I think it was that future planning. And yes, through the ups and downs of dating and marriage and divorce and marriage. And here I am now. Yes, we wanted to have children. And I said it to my husband immediately. I was like, I don't think this is going to be easy, but I want to do it. Like, I was very like, this is what I want. I really want to put diabetes to one side and I want to have a child. And there are people out there with misinformation, especially women with type 1 diabetes, who may be told or made to feel as though it's not for you, it's not going to happen. Like, think of something else. Like, it's not going to happen. It's going to be really hard. How can you keep your sugars in control for like 9 months? What is the key essence to your message that you would say to almost like that Manisha at the age of 20 who was petrified? What would you say to her, especially coming from your professional point of view?
I would say women and birthing people with type 1 diabetes, they're a different breed. If you can get up every day and still try to do your best with your diabetes, you're already doing so much more than most of the population, okay? This you can handle. Women with diabetes are strong to another level, you know, and unstoppable, actually. And I think the key thing is that a lot of the time with diabetes, it's out of control. It's out of your control because your pancreas doesn't work. So you can do the same thing every day and get different results. Yeah. And you can have this narrative to try harder and do this, but your pancreas doesn't work. So take off some of that guilt and own the fact that some things you can't control. So with the pregnancy, it's easier if you focus on the things that you can control. So any self-respecting diabetes specialist midwife always going to go in for the preconception care because we see such better results, easier, smoother pregnancies for people that have preconception care. So it's hard though because life doesn't run that smooth. And I don't know, we might end up talking about my pregnancy journeys, which were kind of wild.
We will.
But with my second, I didn't have preconception care. And with my first, I had about 8 years of preconception care. With my second, I didn't have any. And there was a difference, but maybe not in the way that you would think. I think the key thing is take control. So if you can get to a point where you say it might be on the cards, possibly, that's the time to see your doctor, because there's so much available for people who are preconception. So preconception, that we just mean before you get pregnant, basically. We've got loads of tech. We've got, you know, we can really like fine tune everything, and everything is kind of available for that group of people, that pre-con group. And you manage to get more control and then feel like more able to manage it, I think. And also get your support network in there, you know. Get primed, get ready. I remember when we were trying to get pregnant with my first, and I saw this sort of fertility person. She said, you know, you wouldn't plant your seeds in a block of concrete. She was like, prepare the soil.
I was about to say a really awful word there, because I was like, God,
brutal.
Really brutal.
But she said it might grow. Like, it might grow. You see weeds growing out of brick walls, right? Just how people sometimes have unplanned pregnancies and things. She was like, but if you have the time to put the compost down, put the fertilizer in, and just keep an eye on it and prime the soil, you might find it's a smoother journey. And I thought, oh, it's a bit harsh, but it made sense, you know, just those things. And to people without diabetes, they might think, oh, okay, well, stop drinking coffee, stop having alcohol.
Yes.
Yeah, sure, whatever. But with diabetes, it's more a case of, have I got all the tools in my toolbox to manage this the best I can? And have I got my friends, my families, my colleagues, my boss, are they on board to support me with this?
Totally.
But it's not easy. Like, it would be easy if you were like, right, I'm going to preconception care, I do that for 3 months, I get my HbA1c down, my time in range, and then you get pregnant. It's not really how it works.
That sounds like a film. It sounds like a narrative from a Hollywood blockbuster, because that is not true. As soon as me and my boyfriend, well, now husband, got serious, and I was pressuring him, thinking we need to get married, we're like, no, we have to think about this. So I had that conversation with my amazing diabetes nurse, Lakshmi, and I said to her, this is what I want. What do I do to get me to this point? Yes, I was on a sensor. Yes, I was on a pump, but they weren't a loop of any kind, hybrid closed loop. They were just individual. And she said, we need to try getting you on this. And this will, it's almost, and the way she's described it's quite funny, as my real job as a teacher. She's like, you know, Manisha, before you sit your GCSEs and like in year 10, you do mocks and revision. I was like, that's kind of what you're going to do. And then when it comes to like year 11, you'll sit your exam, which is having the child. I was like, great. I get it. That makes sense in my brain.
I'm slightly nervous, but I like it.
No, but it makes sense.
Let's do a dry run. Yeah.
Absolutely. You know, let's try doing that revision, getting your exam skills, so to speak, and getting your technology in line. And then when you do conceive, it's sort of like you already know what to do, rather than the panic of, oh my goodness, I'm pregnant. And learning this new technology. It's overwhelming. But I know that you were involved in the trials to do with the closed loops, or hybrid closed loops, sorry, I should say. And, you know, you were somebody that was really involved in pioneering it, and in order for it to be rolled out for individuals like me. So firstly, thank you. And secondly, what did the trial entail? How did it come about? And also, what did you have to do within that trial?
So essentially, I was working as a diabetes specialist midwife, and I don't know if you've ever met Professor Helen Murphy. She's sort of the goddess of diabetes in pregnancy for the UK and a little bit, you know, the world. And she was, I've worked with her for a long time, supporting people with diabetes in pregnancy, and we've already had, at that point, had my eldest, who's now 10, and had given up kind of trying for a baby, which had a lot of IVF and things. So I was just focusing on work, and we started the ADAP trial at the Norfolk and Norwich. So it was one of the key sites. There was lots of sites around the country, and it was sort of the last step in a lot of trials about technology in pregnancy. So the predecessors were the ones that trialed a glucose sensor. And it was like the concept trial. It proved that having a glucose sensor in pregnancy gave you more time in target range and better outcomes for mum and baby. So that was pioneering anyway.
Fantastic.
And then, you know, there's the next one, clip 1, clip 2, all these trials that were trialing this technology with this hybrid closed loop. And it was on a computer, on a laptop that you had to carry around with you, one on an iPad. And then this was like the final step. So it's CAM APS, the algorithm, an insulin pump that was compatible. So at that point, it was like a Dana pump or an Ipsomed pump or something. And the algorithm was on a mobile phone. And then so you got the sensor, the pump, and the mobile phone. They all sort of talk to each other, like, you know. So this was the last part of that trial where we were trialling that in pregnancy, because we already knew that was probably going to make a difference. So we started onboarding people at Norfolk and Norwich, and oh my gosh, I was like, what is this madness? And I had already started down the process of, because I'm a bit of a tech lover with diabetes, I was already self-funding a sensor, and I had started on the process of getting my own DIY APS. So like, you know, DIY
quite big
looping.
in the States. Yep, absolutely.
Yeah. So I'd got a new laptop, I'd updated it all. I was working towards getting this Dana pump that would work with it, and it was very complicated. I was writing my own code, and I was like, and I thought, and I'd parked it for about a month, and I was like, I'm just going to get one of these as soon as they come out, and get one of these. And we saw it in front of our very eyes. People, their lives were just changing. It was absolutely mad. And when you went into the trial, you had 2 branches, and it was completely randomized by some person in Australia. And you either got your existing method, which was like an insulin pump, standalone insulin pump like you were on, injections, and you got a sensor, which at that point it was just great to get a free sensor because they weren't really widely available. Or you got this hybrid closed loop, and it just completely transformed everything. It transformed for the women. They would come in and say, I just slept for the first time in 15 years, like properly. Their depression would improve, their quality of life, less hypos. People who previously had to stop work were carrying on working. And the babies were just coming out healthier, and they were having normal births instead of cesareans. And I was like, I can't get over this. And then boom, when I least expected it, I got pregnant, and I was like,
It's meant to be. It was meant to be.
Hello.
Yeah.
So we'd been doing the trial for a while, a year or 2 at that point, and I was really involved in supporting patients on it, and looking at their data and giving advice, and I was getting quite au fait with that. And then I found out I was pregnant, said to Helen, I want in on this trial. Very, very tense moment on a Saturday morning when I'd just recovered from COVID, and had some bleeding. I was 6 weeks and like 3 days or something.
Right.
And we waited until I was just far enough past COVID for one of my colleagues to scan me to check that I was in fact still pregnant. Came in, had a scan, found out, yes, you've not had a miscarriage, you're still pregnant. And Helen was there in my office.
Oh.
Do you want to be randomised? I said, yeah, I do, yeah. And we sat having a cup of tea, waiting for the randomisation to come back from Australia. And then it was like, you've been randomised to hybrid closed loop. And something shifted. It still gives me goosebumps when I think about it. And within a week or 2, I was on hybrid closed loop.
That's
and
amazing.
I've never looked back.
And it's interesting because your 2 pregnancies were so different, I'm assuming.
So different.
Yeah. And the fact is, because, okay, fair. We could argue and say, you know, the technology had come sooner, if the trial was done sooner, whatever it might be. But it's all to do with, like, from a design point of view, the evolution of design. So we could say the first ever Omnipod Eros, which I had back in the day, and then it went from like the Dash, etc. And, you know, now it's, you know, crazy. Apparently it's getting changed again. But I think it's all about the evolution, the funding, where the technology really needs to be driven. And in the UK, correct me if I'm wrong, with NHS England, their focus is on the teens and on women who would like to start a family. And, you know, that's where the funding sort of, there is this cloud of, you know, why can't I have it? Why can't I have this technology? I don't know the answer. But the funding does go to places where there is more risk, perhaps, or there's more need. Is that the correct way to say it?
Yes. So it was the results of the ADAP trial that informed this NICE TA, which is the appraisal for utilising this technology. And it was quite a new thing when that came out, because a lot of the time NICE do guidance, and it's kind of the choice of the trust if they want to implement it. But this is sort of compulsory.
Yes.
So then we worked with NHS England to make sure that there's money ring-fenced for people who are pregnant and who are preconception, because we know from the trials that the great thing with trials in pregnancy is you get instant gratification because, like, yes, we know, it's going to help young people, but we don't know how it's going to impact on their long-term complications for another 60 years. Whereas in pregnancy, we get these instant findings. So we say, oh, well, that definitely helps. And by doing that, you're not just helping the pregnant person, the whole family unit is being affected. And the baby's long-term prognosis, it will reduce the chance of things like the baby being large for gestation age and therefore having a shoulder dystocia, which reduces the chance of cerebral palsy, admissions to NICU. And, these are huge things, both from a personal point of view, but financial as well. So instant changes to, the budget. But the good news is it is a staged rollout. So the first stage is, don't quote me on this, but young people, so people under the age of 18, pregnant people, preconception people, and people with a H1C over like 68 or 69 or something like that. 58 maybe? Oh, I can't quite remember. But it's, it's the first stage. And then the next stage will be, people, and also there's like little loops for like people with disabling hypoglycemia,
of course.
Stuff like that. And you can do like individualized ones. So they're the ones that are funded, immediately funded by the NHS. But everyone will essentially be offered it by the end of the rollout process. Absolutely. And it won't be very long.
No.
And it would be great if we could it could be offered to everybody. But actually, what you really need is intensified support when you put someone on hypoclose sleep, when someone's onboarded, and we're sort of like trying to see how much we can wring out of the process. Like now it used to be that you would do a 5-day course to go when I was put on an insulin pump, a 5-day course in an insulin pump. Now it's been whittled down to about a 3 or 4 hour meeting,
it's
and we now do them in a group. We do about 4 or 5 in a group, but I know that My Life did 28 in a group up north recently, and they're just sort of trying to get people as quickly as they can, but it needs to be the right onboarding. Like if you rush it, it's not safe.
I think that the element of safety, but also being clear as to if you got, for example, a large group of people, how are you going to have that in like initial conversation about these are your numbers, this is your reading, this is how you need to input it. If there's a very small group, it is far easier to sit beside literally that person and go through it. So I did mine at Queen Mary's, and that's exactly what they did to us. There's another 4 women who were pregnant. Some had their partners there, some were just by themselves, and that's exactly how we did it. But then we also got to like meet other women that were pregnant, and
that's nice,
and it was really lovely. Unfortunately I had to go back to work, but life is great. But I just want to clarify, when you were pregnant, you said 10 years ago, because your first child is 10, were you on pens or were you just on a sensor, or what technology did you have?
So I also have a very, very good endocrinologist who's now retired. But she has always known I've been really keen on tech. So I've always been a fairly early adopter. So I was on an insulin pump about 16, 17 years ago. So I was on a pump and I was finger pricking.
Okay.
And I had to, and it was IVF. So we'd had many years of IVF to get pregnant with her. And that is something also, I think, that was obviously really hard. But I had previously been told you're not ready from a diabetes point of view. So we got married instead. And then eventually I managed to get things down because I've always found my diabetes really difficult to manage. I guess everybody does, but it really felt really hard. And they gave me obviously everything they could in terms of technology, because when I was on pens, I was doing about 8 to 10 injections a day trying to get it under control. So then there was the complexities of then being given the green light and it not working. And I had quite a lot of resentment towards the diabetes from that, because I thought, if it wasn't for the diabetes, I'd have tried, several years ago and would have got pregnant really quickly. But you don't know that.
Of course.
And there's not much of a link between diabetes and infertility. So if anyone's listening, don't let that scare you off. That was just
really
my bad
important. You said that, actually. Absolutely. And that's Very important.
Actually, let's just blame my husband. Should we just do that? Because that feels easier. Sorry, Rob. So that was in itself a speed bump I had to get over, and it wasn't easy. And then, eventually after all the Clomid and everything, we did the IVF. And on our third and final IVF cycle, we got pregnant. And so I tried most of that on finger pricks. We managed some... I want to say I had the occasional non-alarming sensor.
Okay.
So
like a flash monitor.
I think it was just coming out at the time.
Right.
Which I'd sort of then carried on after, because I remember having it immediately postnatally. But I had a lot of really retro tech. I had like. I don't know if you ever had the glucose sensors that you then plug into the computer afterwards to get the data off.
I had the phone one, the iPhone one, the G Star.
Very, very retro.
I know.
I want to say this was a Freestyle Navigator. The Freestyle Navigator I wore around my neck.
Oh, God, no.
With a lanyard. And it was like a chip in my back, and it would alarm. That was the first one I had. They'd managed to get hold of it from somewhere, from a rep somewhere, and it would alarm if you went low. But it also alarmed if it was hot or cold, or if it just alarmed. And I went to Bali with that. So they gave me that when we went to Bali, and we're like, this'll kind of save your life. Well, let me tell you, it's pretty hot in Bali, so that was no picnic. But most of the time I had these really retro ones. They were like a funny kind of wobbly shape, and you put it on and you wear it for 2 weeks, and then you take it off and they'd plug it in and they'd say, oh, your blood sugars are all over the place. And I'd go, yeah, I know. And then I was like, and then they would say, so some nights it would go low,
okay,
and I wouldn't wake up, and it would rebound, and I'd wake up in the morning, it'd be really, really high. And then some nights it would just go high, and I'd wake up really, really high. And so they were like, they gave me this sensor to get a grip on that and say like, well, let's find out, is it going low then high or just high? Oh, it was different every night, and they were like, okay, still don't know what to do with your insulin.
I find that's really strange, because even you said it, and we know this. You could be doing the same thing every day, having the same dinner, going to bed at the same time, and it's going to be different. It's going to be absolutely different, and it shouldn't matter to a certain degree. It's all about keeping consistent, but also having a life. Like if you want to go out, or if you want to miss a meal, that is what the hybrid closed loop really, really helps. And like, for example, I mentioned it before, like the ease off. And I know, this is my thing, I know if I have a Chinese takeaway, I have to put Boost on. The Boost is there all the time. And yes, there is a risk that I might go low, but the Boost really, really helps me personally. That's just my body, my system. That's how I work. But even once I was pregnant, I genuinely thought my numbers are just going to be all over the place. But silly things happened to me because I wasn't sleeping in the most comfortable position. My Ipso pump would like detach from me without realizing, because I was moving about so much, and I'd wake up and it would be sky high, and I'd think, oh my God, I've done something to the baby.
So scary.
And I was like, the baby. And I remember
when you're pregnant and that happens, it's the worst.
Frightening, like, digits that I don't want to see, like 18, 20, and you're just like, oh my God, I'm literally going to lose my mind. And I told my consultant, Dr. Chucks, and I said to him, this is what's happened. I have to admit it to you. And I literally was almost going to cry, because I was like, I've done something to the baby. Can I please have a scan? I can't believe what's going on. And he just said to me, he's like, Manisha, let's look at the overall picture. He's like, let's not just look at that night. Let's look at the overall picture. And that actually really helped. Of course, highs and lows are not wonderful, especially at the early stages of pregnancy. However, looking overall, let's just emphasize that. I mean, tell me if I'm wrong. Like, has that ever happened to you? Did you have moments where it's going mental whilst you were pregnant, or have you had patients that have been worried sick about it?
Yeah. And I'm always amazed at the people that come through my service. They, like I said, so strong and so amazing how they're able to prioritize their diabetes, because in real life you can't prioritize your diabetes every day. You've got school runs to do, you've got a job to hold down, you've got to do the food shop, clean the house, you've got bills to pay. You cannot always focus on your diabetes. That's a full-time job. So when people who, you know, are pregnant and they manage to like continue working and things, I'm like, wow, you're amazing. And so there's sort of, people go down different routes, and so sometimes people slightly lose the run of things a little bit, because it's hard to sustain for 9 months.
That's it.
It's really hard to sustain. And I think to those women, I just say, that's fine, just draw a line under it. Like, you know, if you can remember the basics, that's really great. Like if you remember to bolus for a meal, that's really, really great, you know. But also I can fully appreciate that you cannot sustain this 80% time in target range for 9 months without having a bit of a mentee bee. So I feel like, you know, that's okay. But a lot of women actually go the other way and get really, really invested in it, and they're constantly on their phone, constantly tweaking things, changing things. So part of my job as well is to sense check that. Like, does that feel okay? Because you don't need to do that. You know, your glycemia is probably better than someone without diabetes. So if that's impacting on your mental health, it's okay to chill that out. But if you feel better for having that micromanagement, you do you. Like, that's fine. My job is just to walk alongside you on that journey. I'm not going to dictate anything, and try and meet women and birthing people where they're at. Like, does that make sense?
Absolutely.
So for me, I kind of went in fits and starts, you know, and I would find a way, and then I would stick to that. Like, oh, well, that breakfast works, so I'm going to have that breakfast.
Yeah, I did.
Or make a sandwich, and I thought I'll just have half the sandwich first, and then in the afternoon I'll have the other half. You know, that kind of thing. I would find my set things, and then I'd be like, it's working. And then Friday would come and I'd be like, it's not working. Because diabetes just sucks.
I get it.
And you would feel the guilt. And yeah, those times I do get the calls of the didn't realise my cannula was detached, cracked cartridge.
Oh, yeah.
Hypoglycemia is the closest I'll probably get to a cure, but it isn't a cure. It is only as good as the component parts. So if the pump doesn't have a battery in it, if the insulin's empty, if the cannula's kinked or fallen out, you know, if the sensor's not on, you'll still get insulin, obviously. But like, it's only as good as the component parts. And that's where we mess up a little bit as health professionals, to be mindful of that. But patients are amazing. And I don't know about you, but like, do we ever talk about the huge amount of admin involved in having type 1 diabetes?
Oh my.
Well, I've got insulin cartridges in fridges all over the hospital because I'm so terrified I'm going to forget. I'm so forgetful.
I've got some at my dad's house. I've got some at work. Every time I go like out of London, so we were in Birmingham a couple of days ago, I like literally made myself like a little Ziploc bag of a sensor. Some pump, batteries, you know, AAA batteries.
Oh,
you never know, the battery might not work. And literally my husband looked at me and he's like, okay. And I was like, don't judge me. Just in case, you never know. Like, just don't ever know.
Because actually, I've had every eventuality.
Exactly.
I remember being at a wedding on a different pump, and with this different pump, it was like when the batteries were dead, like they were dead, with like no warning. I was at a wedding and I had to steal the batteries out of the remote from the telly behind the bar. I was like, desperate times, mate, desperate times. But like the fear, and like I remember being out on a walk and running out of insulin and being like, okay, I'm just going to sprint this and that'll bring it down.
Well, partly works, yeah.
But it's like there's so much to remember between and remembering the sugar, the insulin, the batteries, the tech, like having spare cannulas. Holidays are not fun, are they?
They're not. But also, I said this the other day. So I was trying to, we took my son, as in the mums and like the babies, we took my son to soft play, and I was like so excited. He's going to crawl, it's going to happen, we're going to go to soft play. And I was trying to find something in the baby bag. I can't remember what it was. Let's just say it was a nappy. And I was holding him because he was being a little pickle. And I said to my friend, I was like, Tessa, could you just have a look in the bag for me? Because I just need to get this thing. She's like, okay, I'll have a look, don't worry. And she like pulled out that little Ziploc bag of all my diabetes bits. She's like,
here's your drugs.
She's like, you're using your son's baby bag for that? I was like, yes, because if mummy is not 100%, my son, he won't be 100%. So that's the only place that I know I'll take him, and that's where the diabetes will be with me, just in case. You never know. And she's like, okay, cool. And then she just carried on finding something else because it was the least expected place that she thought it would be. Okay, fair, you know, it's everywhere. And I also believe what is everywhere. I said this to one of my other mum friend. Whilst they were pregnant, hormones, mental hormones. Don't remember the name of anything. I was eating everything. I was crying, if not screaming. I was quiet, but I was really loud. There's a lot of things happening. What's also having a life. The hormones are, besides the hormones and the way that insulin works, what's being diabetic. So you've got the most fantastic cocktail of when you're diabetic.
Perfect storm, I think we'll call it.
Yes, absolutely. Storm in a teacup. And then being pregnant on top of it. And I personally, the level of anxiety was through the roof. Everything was stressing me out. And I just had to have a chat with myself. And I think it was maybe 20 weeks. And we found out, we were having a boy. And I said to my husband, I was like, I think I need to start enjoying this now. And he's like, yeah. Like in a really sweet way, like, yeah, I think you do.
It is easier said than done.
I know.
It kind of feels like the biggest project you're ever going to do.
Oh, yeah.
And, actually sometimes difficult things happen to people who are pregnant, and to the general population, they just will often just assume that it is just bad luck. But we as people with type 1 diabetes, the assumption is that we've done it, right? We've messed
to
up.
ourselves. Yeah.
And I think you have to kind of let some of that control go a little bit, of the feeling like, if you do this, that's going to happen. If you do that, it's easier said than done, because I did the exact same. But I think giving yourself like a couple of days off sometimes is just a ticket. And I remember we had this with Ada, we had this holiday booked because they'd said that the IVF hadn't worked. There was a problem with the development of the embryos, but we put these dud embryos in anyway because we were like, yeah. So we booked a holiday to Bali, and then it worked. So we were going to cancel it, and I remember my consultant saying, no, you need to go. Like you need to relax, and you need to enjoy your holiday. I was 20 weeks. She was like, you'll be starting to feel the baby move. You need to go and sit on a beach. And you do, because actually it's your mental health, your emotional well-being is as important. Like, it's really, really important. But I think we have quite low standards if you have type 1 diabetes. So, a lot of the time people say, like, lots of people with type 1 diabetes have a cesarean, for example. Actually, a huge amount of those are just maternal choice. And a lot of that is because people have thought, well, it's taken a long time. I've gone through preconception care. I've had like what feels like the longest pregnancy known to man. When you think like you've phoned your midwife at 4 weeks in one day. I mean, if it feels long to you, imagine how long it feels to me.
Of course.
And then you get to the end and they say, well, it might get stuck or da-da-da-da. You're not comparing a water birth on the midwifery-led birthing unit with no monitoring to a cesarean section. You're comparing more medicalised, medical managed labour, probably would be recommended to be induced.
Absolutely, yeah.
Versus a cesarean section. It's no wonder that people say, time for me to have some control, actually.
Absolutely.
I'm ready to end the pregnancy and I'm ready to do it on my terms. I'm having a cesarean section. So while there is an increased risk with diabetes, there's also an element of choice, and people with type 1 diabetes often feel like, do you know what, this has been medicalised enough, I'm just going to do it my way. And they have quite a low benchmark for things that other people would find really challenging.
I think so. And it comes back to being in control. So we know ourselves, we know our condition, and we want to be in control. That's all it is. That is literally the choices that, for example, I've made. The whole idea of like being induced, which didn't go as successfully. So it did become a cesarean. And I actually got to the point where I was like, I just want the baby out in a nice way. Like, I was just like, I've been in here for a couple of days. I feel like really gross. I feel like, I'm really hungry. And like, can we just have the baby out? Like, I'm happy. I think it was a Sunday. I was like, oh, it's a lovely Sunday morning. Let's go. Get it out. Let's go. Yeah, and I think that's what it is. And, and depending on where you're with and how well you know the team, for example, just be honest with them and say and feel empowered that you can have a choice. I was very specific. I said, if we're doing this, I was like, how soon can I do it? And they said, yep, we've got space. We could do it within the next hour. I was like, okay, fantastic. And I literally was like, can I play my own music? And I was just like, and it sounds like a weird thing to say, but I was like, I don't like the clinicalness of all of it. I was just like, I didn't enjoy that. So I was just like, if I've got music, I know in my brain it can like have a memory, and I really like this memory, and it makes me feel chilled. And it's a good song for me and my husband's, our wedding song. It would just really help me just to feel relaxed. So nice. And it was, and yes, I don't remember it very clearly, but I do remember the song. It was My Sweet Lord by George Harrison that my son was born to. And I will never forget it because I felt so, well, high as a kite, but I felt very calm and very chilled. And that was my control. But the biggest control I had was I could wear my devices. I was able to wear everything. The system was still there. I remember my Ipso pump. Yeah, my Ipso pump, I think it was just over here because I usually wear it on my arm. It was just over here. They wrapped it up in a little bit of cling film for hygiene purposes. Fine, go for it. It's just there. And my husband knew how to change it. He knew the settings once the baby had come to revert it to, because my consultant had documented it. Yeah,
the postnatal plan, that's very important.
Very important. Everything was explained. The midwife, just fantastic. The surgeon, fantastic. I know there's women and families out there that don't have this level of care. And I know it can really, really set a negative tone. But for me, I thought it was really important to ask the stupid questions or silly questions, ask the most bizarrest things, be firm of reasons why you would like to still wear this, or I would like to do this, or how does this work? Even if you're not sound of mind, then have your partner or family member, your support network, be that voice that you can't be. And do you find that when, you've got, say, a family who's going to give birth, say they're at, 39 weeks and they may be having the induction, or they're like, actually, let's see. Do you think that they are headstrong and sound of mind as to what they want? Or do you think they're a bit more like, oh, let's see how it goes, or we're not sure what this entails?
We get a bit of everything, to be honest with you. And my job is to, so really I support anyone to make any decision as long as it is informed. So as long as I give the information, and then I can wait and give them let them sit in the space to think about it, so that they have time, support and information to make the best decision for them. And if they've done all of that, and they've maybe done their own research, spoken to their family members, and they decide, I don't want to be induced and I want to delay it for a week, then I can put in support mechanisms, extra scans, listening to the baby, a direct contact number if they change their mind. And so we and that's why I think midwives play such an important role in supporting people with diabetes. A lot of the time when I go teaching around the country, people say, it's a bit weird that you're a midwife and you're so involved in the diabetes. Midwives are trained to support women and birthing people at the hardest time of their life.
Absolutely.
Okay? So we are the professional friend. We hold space for women and birthing people when they are having a really difficult time. I see that as making a decision about the birth. I see that as trying to relinquish control when you've just gone on hybrid closed loop and you've been doing injections for the last 20 years. I see that as these transitions, these difficult days with the cannula coming detached, the correct cartridge, anything like that. I am the best person to do that, I feel. And not in a kind of egotistical way, but I am a midwife.
I agree.
I am with women. That is my whole job.
Absolutely.
And sometimes it's hard and sometimes it's easy. But for these people that say, I can't do this, I'm 36 weeks and I can't go any further, I'll hold their hand until it's as safe as possible to have that baby. And for those women who reach 38 weeks and they say, I'm not ready, I don't want this medical interference, I will say, okay, let's do what we can. Let's meet you where you are. This is the information, sometimes it's hard to hear the risks, but I will hold you in this space until you're ready. Because so much of the time when we speak to people on the phone and they say, oh, so have I got to be induced now? And I was like, you haven't got to do anything.
Exactly.
Like, you will be offered. And we do need to change that narrative. And I'm so lucky because I work with some amazing doctors, obstetricians and diabetologists. But where we say, you know, don't forget, I'm offering you an induction of labour. I'm offering you a cesarean section at this point. How does it feel? Not you need a cesarean section. And also to change that narrative of about who it's for, because in the past we would say we want you to have the baby by 38 weeks, but actually it doesn't matter what I want.
It's not. Absolutely.
It's not about making me feel better. No. It's about what is right for you and your family unit. So that's why I feel so passionately about midwives being involved in diabetes, particularly with type 1 diabetes. I really, really think we could be really well placed.
And I think for me, absolutely. For me, it was just a case of sharing that load. And I mean literally the load. Seeing my midwife every couple of weeks and having a chat, but not just talking shop, not just talk about babies, just talking about anything, like something that was on the telly, but also just having somebody that really understood you. As much as like my husband understands that, pregnancy is a bit much, isn't it? But he doesn't understand what it's like with diabetes. He can see what it's like. He's known me for years, but he will never feel what I feel. He will never feel what it's like, that kind of guilt, I say, about, am I doing this right? Should I eat this? And, you know, you mentioned eating the same food. During my whole pregnancy, I would have the same lunch every single day. And I'll be honest with you, I didn't get bored of it. I quite enjoyed it. But it was very regimented. But being a support network for somebody who's actually, in my opinion, when I was pregnant, I didn't really think too much about myself. I was like, is the baby okay? Is the baby, if I do this, is the baby okay? And it took me a shift to think, actually, I need to fill my cup in order for the baby to be okay. The baby's swimming around, having a lovely time. So luxe in there. You know, the oven was, you know, a lovely oven, I would say. But for me, I just really got in my head. And I also think your role, just saying, I think, is to be there for our mental health and supporting us through those doubts that we have. And many women may not feel comfortable sharing those doubts because, you know, I'm in control, I'm holding the baby. But you do need to loosen those shoulders and you do need to say, I'm really petrified of this thing. I'm not sure what's happening. You know, I was offered an induction and yes, I chose to, but as we know, it didn't go according to plan. I was adamant not to have the C-section. Because I knew the recovery would just be just beyond, you know, belief. Especially that, you know, I don't have my mum anymore. And yes, my amazing mother-in-law stayed with us and she really, bless her, Lynn Wareham, like you really did support me and my husband. I might cry. And obviously my son.
Go, Lynn.
Yeah, she's amazing. But a lot of people don't have that. And a C-section is a major operation. And I've said this a few times to some close friends, you know, I really wanted to breastfeed. Like I was adamant to breastfeed. And actually I couldn't, mainly really because, hard. After the C-section, it just couldn't get in that position. He just wouldn't latch on. And the load was a lot, you know, the mental load was a lot. And he's fine. He's a formula fed baby. He's rocking and rolling.
I think it is really hard. And I think also with diabetes, it is hard because it can make your blood sugars go low. But we know that people with diabetes, the breastfeeding rates are slightly lower because actually there's a mechanism, a process, which is different when your milk comes in. So you get delayed lactogenesis too. So like you're already a little bit on a back foot. So if anyone listening to this has got type 1 diabetes and has managed to breastfeed, like you are my hero. Yeah. There's nothing stopping you if you get the right support. And I'm a midwife, so I should be able to breastfeed. And with my first, it was hard, really, really hard. And she had jaundice and was on the NICU and she was tube fed. And my one thing is that I don't want any formula because the midwife in me was like, I don't want any formula. And she had bucket loads of formula. Yeah. She had absolutely litres of the stuff. And then we managed to get on top of it and we did breastfeed. And then with my second, it was just smooth sailing. Second time around, it generally is easier. But again, it's about having the right support in place. So there's, there's both sides. There's no reason that if someone's listening to this, there's no reason that you won't be able to breastfeed.
Of course.
But you will need to get your support mechanism in place. And the same as if you've got diabetes or you haven't got diabetes, breastfeeding is just hard. For some people, it's easy and it just comes naturally. For other people, it is a bit of a struggle. And for me, I did it for a year for both of them, but it was kind of hard the whole time.
Of course.
But that's probably part of that being a midwife pressure that you should do the feeding. Do you know what I mean?
And there's loads of not clubs is the wrong word. There's loads of clinics to support breastfeeding, and they will know about you because you can provide your NHS number, and they'll know that you have, say, diabetes, and what support you need. And I think that's really important. That I say that there's a lovely lady called Jules, who is a midwife who specialises in breastfeeding. When we used to live in Harrow, and she really tried with me. She really tried. Yeah. And I think she also noticed there was once where she just said, "What is the reason why you want to breastfeed?" It's the reason. She just said it to me straight. I said, "Well, I've been told, breast is best and all that kind of stuff. And, I think it's really important. It's very natural." And she said, "But what impact is it having on you, Manisha?" And I literally cried. I just said, it's a lot. I can't do it. This is just too much happening. I can't. It's a lot. Yeah. She goes, "Well, I think it's time that you make a decision in that case." And we went home, we had a chat, talking to my husband. I think he was thinking it, but walking on eggshells around a postpartum, wife, after, a custard cream and a biscuit and a cup of tea. And he's like, "How are you feeling?" And I was like, "Yes, I think I've made the decision. I don't think it's not happening." And actually, he's involved in feeding our son. I can have a bit of a rest, especially in the nights early on. And it has helped in our relationship, in our household. But there is support out there, is what I really want to emphasise.
I do think also that there is a real place for specialised support. At the Norfolk and Norwich, we've got a diabetes infant feeding team. So we have a specialist team, which consists of sort of care assistants, lactation trained specialist midwives that are specialist infant feeding midwives, and lactation consultants. And the work they've done is amazing. And because they specialise, they've been able to audit that and see that people who have that specialist support have a much higher rate of continuing breastfeeding at the time of discharge. And then again, not always breastfeeding, but giving breast milk as well.
That's a good way.
And then they've been part of the Heart's Milk Bank, which is a national milk bank. They're doing a lot of work with them on a project with donor human milk, where people with diabetes, specifically type 1, type 2, gestational MODY diabetes, they meet with all of the people on our caseload who are interested, and then they pre-consent them for donor human milk if they would like it. And then when they've had the baby, if they're having trouble with feeding and the baby needs to have a top-up, or is recommended to have a top-up for like blood sugar reasons and things, weight loss, they can then access donor human milk, which is normally reserved for babies on the NICU. And it is just beneficial, particularly for people with gestational diabetes and type 2 diabetes, because those people, the act of breastfeeding does reduce the baby's incidence of getting type 2 diabetes. So that's a different genetic kind of pathway. And it also, for people that have donor human milk, they end up being more likely to then, because they don't just get given the milk, they get given a support package of pumping and all of this stuff, and they're more likely to get back onto the breastfeeding. And if you have type 2 diabetes and you breastfeed, so if you have gestational diabetes and you breastfeed, you're less likely to get type 2 diabetes after the birth.
That's
incredible. It's a really good intervention. So I wish every hospital did that. The work that Lucy and our team at the Norfolk and Norwich have done, Sophie, is incredible. And really proud of that. So we refer people to them, and they just email every single person on our caseload. So we need this tailored support. People with diabetes have a different journey to other people, and supporting people, you know, in the hospital and afterwards with that is really important.
I definitely think the postpartum, and, you know, in a nutshell, it is, you know, the beginning, middle, and end, so to speak. So it is that initial preconception, then it's the pregnancy, then it's the postpartum. And all of these are significantly different. The impact that it has on our blood sugars is absolutely different, totally different. But
So
what
different.
what I would say is this, you know, we could talk for hours, but what I would say is the research is out there, the information is out there. There are more women who with type 1 diabetes who have had a family who are talking about their experiences. And what you will realize, and I say this to, you know, anybody, you know, who's considering having a family in the future, that everybody's journeys are different. What worked for me, what worked for yourself, Nina, what worked for my best mate, Julie, who had a son, is different because we are different. As diabetics, we're different. You know, you could have a sausage roll and so could I, and my sugars would do something weird and yours would be great. Mine would be vegan, but yours will not. You know, this is the thing, and pregnancy is supposed to be ups, downs, lefts, rights. But with diabetes, it is the drops and the rises are more rapid. Just being prepared for that information, I think it's important. But more so, people like yourselves supporting us is, you know, the golden ticket. You know, we need that level of care across, you know, everywhere. I know it's not the same for people that are listening. I know it's difficult. I know, you know, people are fighting for a pump, and it's literally, fighting for a pump.
It shouldn't be that way. And trust me, I'm working on it. If you're listening to this, I'm working on it. We're working on it. You are a priority. If you're wanting to go on hybrid closed loop, you will get it. And also, don't be afraid to look at other options. Like if your healthcare provider isn't giving you what you want, what about the next one along? You've got to, you know, put yourself first in those situations. But times are changing. Life is going to get easier and better for people with type 1 diabetes. I really believe it. But find your network, you know, and if anyone out there doesn't have a network, just come find me. Because I love supporting people with diabetes in pregnancy or before or after.
There are so many people out there that can give you advice. There's so many people there who can point you in the right direction. And just approach them, just message them, you know, yourself, myself. There's loads of people out there that can help. And I think it's really important if you say, you know, and I've done this in the past, where your healthcare provider may not be supporting you. In a I wouldn't say in a breakup way, because that sounds very harsh, but I do believe that you have options. I nominated my hospital of where I gave birth. So I gave birth at Queen Charlotte's Hospital, which specialise in maternity, babies. You know, I would have just been given the hospital down the road. But I wanted to go somewhere where I knew that level of care was top. And yes, it was a bit of a trek, but I made that choice because I knew I would get what I needed from there. And you have that choice. As we do with our diabetes, we have a choice. And that needs to continue through that process of motherhood, in my belief. What would you like to end with, Nina? What would you like to say? Any advice or any golden tickets you would like to leave anybody who's listening that may be pregnant currently, or somebody that may be expecting or hoping to be pregnant? You know, you've said some wonderful things that are really comforting. I really am fighting back the tears, if I'm honest with you, because we need more people like yourself. But what would you say to those women out there with type 1 diabetes?
Oh, thank you. I really feel like when you're having your tricky days, I think it's really important to remember your strength. I often think, and I sometimes say to my patients, just imagine how your husband would feel if he had one hypo in the morning. They'd probably be off sick from work for the rest of the day. Like just put it into perspective. You are definitely, all of you women and birthing people out there with type 1 diabetes are strong, really, really strong, stronger than you realize. So while this will be a challenge, and it might be the hardest challenge you'll ever go through, you will succeed and it will pass. Don't try and feel guilty. Try to just relinquish that control a little bit and just say, okay, well, that's out of my control. And just remember, pancreas no worky, like, that's not your fault. You are stronger than you realise, and you will get through it. But be honest with yourself, and be honest with your family and your supporters. Find your support network. And if you don't have anyone, your midwife can be your support network. That's what they're there for. Don't be afraid to reach out. And remember that us diabetes specialist midwives, we don't just care about diabetes. We care about everything.
Absolutely.
Like, come to us. Yeah.
Yeah, you're a wealth of knowledge. And I think that's really, really important. And the fact that you've experienced it yourself, it's not a textbook. It's your own lived experience that you can lean into to help those women. It's a shame that you don't work in London. It's a shame that you're not.
We'll travel.
Yeah, exactly. I know. We could have actually spoken for hours and hours. And still to this day, I'm just admire the incredible work that she does, having type 1, going through her journey and campaigning for women like myself, and maybe someone out there who's actually listening to this as well. Thank you so much for listening, everybody. This podcast is written and presented by myself, Manisha Budgama. It's produced by Matt Wareham, and it's a Depicted production for Diabetes Squad.